Good evening and welcome to the Canadian Concussion Center's webinar series, which is sponsored by the Laborers International Union of North America. My name is Leslie Rattan. I'm really pleased to be moderating our series, which was developed for individuals that have suffered a concussion, their caregivers, as well as healthcare providers. If you haven't been with us before, our sessions recur every other week live on Tuesday evenings from 6 to 7 p.m. And just so you know, all of our sessions are recorded, so you can always go back and access previous sessions, or you'll be able to view this one usually about a week after the live event. So the first half of our webinar typically features an expert speaker, and then during the second half of the session, you're able to get your questions answered. Just to orient you a little bit, if you haven't been with us, if you just sort of move your cursor, you'll see that there's a chat button. In the chat, you'll see actually Christian, thank you very much. He's posted the link to our website where you can find all of our recordings. If you have any questions tonight for our speaker, I would ask that you enter those into the Q&A, and you can get those answered after the talk. Just before going any further, we always like to begin by acknowledging the Indigenous peoples of all the lands that we're on today. Even as we're meeting virtually, it's important to recognize the lands we each call home and reaffirm our commitment to improving relationships and understanding with local Indigenous peoples. From coast to coast, we honor the ancestral and unceded territory of all the Inuit, Métis, and First Nation peoples that call this land home. Next, we're just going to run a quick poll, as we always do, just to get a sense of who is in our audience. Thank you, Christian. And moving on to our speaker tonight. So I'm really happy to welcome back Dr. David Gold, who's going to be presenting neuropsychological assessment in persisting concussion symptoms. Dr. Gold is a staff psychologist at Toronto Western Hospital. He provides neuropsychological consultation for the Canadian Concussion Centre, as well as other divisions of the Krembil Brain Institute, primarily the epilepsy surgical program. Dr. Gold is an assistant professor in the Department of Psychiatry at the University of Toronto and a clinician investigator at UHN. His doctoral and postdoctoral research examined event cognition and the cognitive neuropsychology of aging, while his current research interests include questions about the cognitive neuroscience of memory and the intersection of neurology and psychiatry. And with that, I'm going to turn it over to Dr. Gold.
Thank you, Leslie. I'm just going to get my slides up. So I'm excited to talk to the group. And how does that look?
Looks good.
Okay, great. Yeah, so I'll get started. And looking forward to our questions and the chance to talk to people about what they've noticed and, excuse me, what kind of questions they have. And I'll provide a little bit of an overview of what I'm going to talk about today. And so what I'd like to start with is just understanding how do we go from the brain to thinking skills. So there's a leap, and I feel like the more people understand this leap from how do we go from the organ of the brain, the structure of the brain into this thing called thinking skills, I think that that's something that really benefits people and helps them understand cognition. And we're going to talk a little bit about different parts of the brain and what they do, what their major functions are. And then, important for today's discussion is how does a brain injury impact thinking skills? And so some of the people on this call will be wondering, post-concussion or post some sort of brain injury, how can I understand what's happened to my thinking skills? And so we'll talk a little bit about how we go from neurons or an impact of a brain injury to how it impacts thinking or how structures in the brain function. And then I want to give you a little peek inside the curtain of neuropsychology. So in neuropsychology, our job is to assess cognition. And so I would be curious to kind of teach people about what it's like to assess thinking skills and how we do it, and to be able to relate that to how thinking skills can be impacted with brain injury. And so here's a picture of the brain, and our brain is organized into four major lobes. And at the front part of our brain is the frontal lobe in blue. And the frontal lobe is an important brain structure. It occupies the most real estate and the most important real estate in the brain. And its primary role is involved in this ability called executive function. So we'll talk a little bit about what executive function is. But just to give you a preview, it's kind of like being the CEO of the brain. It's knowing when to start and when to stop, how to multitask, how to balance things. So it's the chief executive of our brain, and it's involved in kind of planning and problem solving and reasoning and being mentally flexible. And so it plays an important role in a lot of different types of thinking skills and can be affected by concussion and brain injuries. The temporal lobe is another part of our brain, and that's important for memory and language. The parietal lobe is towards the top and back part of our brain, and that's important for visual spatial skills and perceiving and seeing things. And the occipital lobe is an important part of our brain, more for the core primary part of vision and seeing the world, not through the actual organ of the eyes, but processing visual images go to the back of our brain in the occipital lobe. And so we have four major brain regions, each with a type of skill that they're really specialized for. And so the temporal lobes for memory and language, parietal lobes more for visual spatial skills, frontal lobes more for executive function. And so what's important to understand is how do we go from a neuron to cognition? And so neurons are the major communicating um, kind of part of our brain in terms of how different parts of our brain talk to each other. They communicate through neurons. And so we get electrical signals that are sometimes transferred through these little neurotransmitters. They tell two neurons when to talk to each other or when not to talk to each other. And so we have an electrical connection. We also have a chemical interaction. And over the course of a large number of neurons, in the order of billions and trillions, we get this network of connection between our different parts of our brain. And so neurons talk to each other through these networks of activation. And so, in understanding how neurons work, we can begin to appreciate, what is the language in our brain? How does one region talk to another region, or within a region, how do we produce thought? And the neurons are the way that we do that by talking to each other. And so neurons talk to each other in a way that's a lot like internet connectivity. We have networks and hubs. And so it's not just a single neuron or a collection of neurons, it's actually a pattern of neural activation that forms these codes in the brain that allow information to be transferred. So when we have memory codes, we're talking about different clusters of neurons talking to each other, activating different hubs, saying to one region it's time to get active, and telling another region it's time to be quiet. And so we get these patterns of network activation that allow us to do really complicated things like remember information or shift between things or perceive things or look for words and other sorts of higher order cognitive skills. And so the more I work in the area of brain health, I'm starting to think of the brain as a symphony. And when we go from a neuron to networks of neurons and understanding brain regions, I'm starting to think of it more like an orchestral symphony where we have different players. And if they're not all playing together at the right time and getting active when they need to and being quiet when they don't, we see something that sounds really disorganized and terrible. And um, in the brain, when we get this wonderful cognition, I think what we're really experiencing is a symphony of neural activity that's acting in a coordinated and sophisticated way. So when I think of brain function and how we can do such incredible things with our brain, I'm starting to think of it like a symphony that's pulling on different players at different times with other instruments being featured and very prominent at some times and playing together and working off of other players in the orchestra, and at other times being quiet and listening to other players. But everyone's really working together and it's targeted and it's synchronous. And so if we disrupt that flow of information in the brain, that's when we start to see trouble in our brain communicating within itself in order to get information from particular areas or to transfer information to different areas. And one example is with a brain injury. When we hit the brain, we're actually hitting our head against an object at times, or our body's moving and our brain is moving at a different speed. We can sometimes injure our brain by hitting a different object. And what's happening is we get these coup and contra coup injury where the brain is actually moving within the skull. And sometimes injuries to our brain are as a result of the rapid movement of the brain hitting the skull, or the counter injury of the force being applied on the opposite side as the brain tries to return back to its homeostatic position. And when that happens, we sometimes see disrupted neuronal communication. So these neurons that talk to each other and communicate with electrical and chemical activity, they're no longer able to do so. And sometimes with a brain injury, we don't even see a particular scar in the brain, like a lesion or encephalomalacia, swelling of some sort. So sometimes we do with more severe injuries, and that's where we see damage to axons or dendrites. We can see this axonal shredding. We can sometimes see nerves that are injured in the brain, these particular neurons. But other times, what we're appreciating is a more subtle injury where the neuronal communication is disrupted. So the way that neurons talk to each other and the way the brain kind of activates in a symphony-like way is being disrupted. And so I use the example of a mood disorder like depression. And we've done these imaging studies where we'll have people who are experiencing symptoms of depression come into the scanner, and we'll have them just rest and close their eyes. And when we look at a depressed brain versus a normal brain, we see different patterns of brain activation. And there's almost like a signature activation pattern in the depressed brain that shows us that someone's experiencing depression. And it's different than a normal brain. And some of it has to do with how different brain chemicals are being transferred across different synapses. And at other times, it's the way that the different brain regions are recruiting baseline activation capacity. But it tells us that in some way, someone experiencing depression is having different brain activity. And I relate that to concussion. And when we look at different studies of how is the concussed brain different, one example is that when you're in a functional MRI, an MRI where you're doing something inside the scanner, and you just close your eyes and let your mind wander, that there's different patterns of activation in individuals who are experiencing persistent concussion symptoms that distinguish them from people who are experiencing other things like pain or other sorts of medical challenges. And so we know that at a very subtle level, the way that the brain is activating or recruiting itself at rest is different than in individuals who don't have concussion. So we know that the brain is different in those experiencing these persistent concussion symptoms. And when you ask people, well, what does persistent concussion symptoms look like? How can we tell which type of individual will experience which symptom? And the answer is we don't know. There's a huge wide range of symptoms, and it's difficult to predict who will have which symptoms or a cluster of symptoms. But the fact that there's so many different types of symptoms tells us, to me, that it's more of a network disruption issue as opposed to one specific type of thinking skill that's always impacted when people have persistent concussion. So there's not a characteristic or a particular type of thinking skill that's impacted. It tends to be broad, and some individuals have a very wide range of clinical symptoms, and it seems as though most aspects of thinking are impacted. And other people may have one or two key symptoms. Some might have specific physical symptoms that are very bothersome, like light sensitivity or computer screen intolerance, whereas other people may have significant difficulties with sleep or with their mood. And so there are different phenotypes or expressions of persistent concussion symptoms. But one thing I looked at in a recent study that came out in 2026 was trying to predict, like, what sort of factors are there that impact who's going to experience which type of post-concussion symptom. And when we look at a large group of people in what we call a meta-analysis, it collapses across a number of studies and it asks the question, what sort of factors or experiences are important for predicting who's going to have post-concussion symptoms? And if individuals have a motor vehicle accident, they're slightly more likely than a different sort of brain injury, like one from sports. If there's loss of consciousness associated with the injury, they're more likely than if there's not. Female sex is higher than male sex in terms of likelihood of developing persisting symptoms. And if there's a large degree of symptom burden right away, that's also predictive of a longer recovery. And pre-injury mental health. So individuals who may have had something like ADHD or depression or anxiety prior to their brain injury, that puts them at a slightly higher risk of having persisting symptoms after concussion. And some of these factors are additive. So female sex plus pre-injury mental health can put you at a higher risk of developing persisting symptoms. So once again, it doesn't tell us who is likely to have it. It doesn't tell us why they're likely to have it, but it does paint a picture of who's at a higher risk for developing persisting symptoms after concussion. And so when we look at the different types of symptoms that individuals can have, one way of grouping them are things related to the physical. So things like headache or dizziness or nausea, vomiting, balance issues. The other is to group them around cognitive issues, feeling of brain fog I hear from our patients, or feeling slowed down in my thinking, or difficulty concentrating, or memory difficulty. Another cluster of symptoms is around emotional or psychological, so feeling not inspired to do things, feeling down, feeling irritable, feeling moody. And another primary cluster symptom involves sleep. So difficulty falling asleep, difficulty staying asleep, not feeling energetic, not feeling rested after sleep. So disruption in the sleep system. And so when Dr. Tatter or other colleagues say, well, what kind of thinking skills might be impacted after this individual's brain injury? It could be sustaining attention could be a challenge. It could be thinking is slowed down. It could be that exerting myself cognitively feels difficult. And when I do, I feel completely spent. So I can't spend a lot of cognitive energy. And when I do, I feel mentally exhausted. Learning new information can be challenging. Multitasking can be challenging. Finding the word you're looking for to express yourself can be challenging. Being mentally flexible, like switching between one thing, or stopping and starting can be challenging. Excuse me, and other types of cognition. So there's different ways that cognition can be impacted by our brain injury. And so let's begin by talking a little bit about executive function. And once again, we're focusing in on the frontal lobe because that part of the brain is most often associated with executive function. And so when we think about the frontal lobe and executive function, you know, let's take a little peek at our tests and how we assess that. And so one type of executive function is the ability of reasoning and problem solving. So an example of a task I'll do with my patients could be to show a pattern like this up on the screen and say, okay, which one of these patterns below, A, B, C, D, E, or F, best completes the pattern above? And in doing so, they're using a type of reasoning to try to say, how do I complete this pattern? Another type of reasoning problem solving could be the ability to abstract and to say, how can I understand the higher level concept that's at play? Like sunlight is a great disinfectant, the ability to think abstractly. Or we could have particular problem solving activities like a maze task where you have to follow your way out of the maze as quickly as possible. Or we could ask you to solve an everyday problem, like if a train leaves at 7 a.m. from Oakville, traveling at 90 kilometers an hour for 320 kilometers to Kingston, when will it arrive? And in doing so, you're using mental math or you're doing some sort of reasoning about how do you solve that problem. Another type of skill related to executive function is our attention span, and that refers to how much we can hold on to at any given time. So the way I describe it to people is kind of like before we had cell phones, the idea of holding on to information before you could write it down. So if someone would say, okay, here's my phone number, try to remember it, or here's 3 or 4 pieces of information, I want you to try to hold on to it. And so that's kind of like the amount of material that we can hold on to before it disappears. And so an example of a task I might do is I might say, okay, how many of these items can you remember? And so I might give you some colors and say, what was the third color I showed you, or how many squares do you see, or how many triangles, or how many crosses? So being able to assess how much you can hold on to in a given moment. I might give you some numbers and say, okay, 7, 4, 2, 3, 5, and ask you to say them in reverse order and hold on to them. Or I might give you some numbers and I'd say, okay, I want you to keep adding numbers on in order to continue with a particular pattern. Or I might give you 2 successive numbers and ask you to subtract the difference between the 2 numbers. And so those are examples of working memory tasks and how we assess them. Another type of thinking skill is this multitasking visual search ability. And there's a lot of different ways that I could assess different types of thinking skills within these parameters. And so an example is I might ask you to only select particular numbers in an array. So you have to ignore the letters and just select numbers. Or I might ask you to select particular numbers like even numbers or odd numbers and ignore a different type of distractor. Or I might ask you to rapidly, cross out or circle particular numbers. Like this time, I want you to only select the number 2. And so those are all ways of playing with attention and multitasking that you have to hold on to a couple more things at a time and ignore a different type of stimuli. Another type of thinking skill is inhibition. And just with timing, I found practicing this one doesn't go as well. But for instance, if we were to name some fruit, and every time I named a fruit, you'd have to clap. And so I'd say, mangoes, kiwis, oranges, apples, and each time I named a fruit, you had to clap. And then maybe I'll throw in a distractor item like a fan or a chair. And sometimes you'll notice that you'll still clap even though you didn't mean to. And so that would be an example of a failure to inhibit. And so we often do that where we mean to hit the brakes mentally, but we actually don't. Another example I think of is when you're trying not to swear and it still comes out and you say, "Oh, gosh, I still swore." And so those are examples of inhibition or hitting the brakes mentally. And sometimes that can be impacted by concussion, and it's a type of executive function. Another type of example I could give you would be a computerized task where I'd ask you to hit the space bar when there's a particular target, and then I'd ask you not to when that target's not there. And so we could test your ability to sustain attention over time and hit the space bar when you see a target and inhibit hitting the space bar when that target is not there. And when we think about memory, I try to think about memory as different processes. And so we have encoding and storage and retrieval. And so encoding refers to getting things into memory. Storage is referring to maintaining things in memory, and retrieval refers to getting things out of memory. So to learn new information, we encode it. And so that could be studying for a test, and it's stored in our memory networks. And retrieval would be, for instance, if you write the test or test yourself and you want to get the answer out of your memory, you'd be retrieving it from memory. And so, when we're doing neuropsychological testing of memory, we'd be looking at people's ability to try to learn different words. And so I might give people a word list where I give these different items. And typically I would read it out loud and I'd say, okay, horn, grass, bass, cement, cleats, boots, piano, loafers, mud, plastic, trombone, sandals. And then I'd say, okay, now tell me as many as you can remember. And then with most memory tests, we do it more than once. And we do that because we want to test how much do you benefit from repetition? So to what extent is repetition helpful? So for a healthy memory system, hearing things more than one time serves to boost our memory. Whereas when individuals are struggling with memory or the strategy processes to get things into memory, that can make it harder to learn new information. And so that's the way we assessed it. And we'll sometimes ask people, was a word on the list, yes or no? And the reason we do that is we think about supporting their retrieval. And so that's helping the retrieval process and a test, kind of testing memory in a pure process type of way to say, even when I help your memory, are you able to get the answer? And so these are targets, and sometimes there's lures. And so we're asking the question, do you recognize this information? And if you do, it means it's not forgotten. But sometimes people need the support of recognition in order to be able to retrieve information. We don't just assess learning with verbal information, we also use visual spatial information. So here's a mock-up of a type of visual memory test that we would do together where we'd show different objects, and ideally they'd be different designs that don't have names, so they're more process pure. And I might ask you to draw them, I might ask you to recognize where they are in space. And then I might show you those items later and say, okay, tell me as many of those as you can recognize. And another type of thinking skill that we assess is naming or word finding. And so this type of task is called confrontation naming. I show an object and I say, what's the name for it? And if people can't recall it right off the bat, I might say, okay, here's a clue. It starts with the sound, oh, and they'd say, oh, it's pencil. Okay, I got it. And so if I'm giving you that clue, I'm helping your retrieval process, and that's called retrieval support. And so when we think about the nuts and bolts of a neuropsych assessment, part of the time we spend together is understanding what you've noticed in daily life. So there's a whole different range of clinical symptoms that we talked about earlier, things that can impact memory, your mood, how you're feeling, how you're doing. And so it's really important to spend time together understanding what people have noticed in daily life, how it's impacted them, but also whether or not it's a change for them. And so for some individuals, they may have had thinking difficulties long before a brain injury, or they may have particular developmental presentations that have always impacted thinking. So an example that comes to mind is something like dyslexia, where it's not a new difficulty with language processing, but something that they've always had a challenge with. And so, as I've shown in the different array of thinking skills, we don't just test one thinking ability. And even though executive function may be the most likely thinking ability to be impacted by a concussion, we still test cognition across different domains in order to develop a pattern of thinking strengths and weaknesses. And we provide feedback. And feedback's really important for people to understand what they've done and, more importantly, what their cognitive strengths and weaknesses are. And so when we're comparing people, we're comparing them to themselves. What are your personal strengths and weaknesses? But we're also comparing them to the population to say, relative to other people, how unlikely or likely is a particular finding. And so here's a little mock-up of someone's particular pattern of strengths and weaknesses. And as when the line goes across and goes further to the right, what it's showing is something that's stronger. So the purple and blue are things that are really good. They're superior, above average. And the red and the orangish colors, those are things that are below average. And so for this particular example, this person's got strengths in memory and they've got pretty good processing speed. Where they're a little bit weaker would be attention and executive function. And so this would be an example of someone's personal or idiosyncratic strengths and weaknesses. And so we take that interview and we get information about how people are doing and what they've noticed. We pick particular tests that are based on what they've noticed in daily life. And we try to see relative to what we know about an individual, is it consistent with other types of medical information, things like EEG in the example of something like epilepsy or seizures. Is it consistent with any sort of structural findings in the case of a concussion or a stroke or other sorts of medical information? So some of the common challenges we face is that we live in a city and a part of the world where a lot of individuals' first language isn't English. And so how do we assess their thinking skills in a different language? There's also the challenge of individuals who have really good thinking skills. And the question is, well, to what extent is this a very subtle or mild change in cognition? Some individuals come to us having completed multiple tests before, and different conclusions have been drawn based on a single test that's been done multiple times, or overinterpreted a single test in a particular environment, and also helping to understand, well, what is the role of mood and cognition for this individual? So, to what extent could things like anxiety or depressed mood be impacting cognition? And that's something that we have specialized training in trying to appreciate in people's patterns. And so just to fill you in on how we address some of these challenges, we use interpreters, we use broad materials that are valid in different cultures, and we try to use sensitive materials that are appropriate for different groups. For people with high baselines, we have very sophisticated tests that have very high ceilings to them. And so we're able to detect relative strengths and weaknesses. We're able to optimize the testing environment and try to get people's best performance and interpret what is a reliable practice effect or change on a test. So if people have done testing multiple times, we're able to interpret whether someone's lack of improvement on a test is actually indicative of a problem. And we're able to interpret the role of mood and cognition with the training in understanding different cognitive profiles. And so at the end of the day, we're left with kind of the diagnosis of a particular pattern of cognitive strengths and weaknesses, whether it fits with what we know. We're sometimes able to diagnose particular types of learning difficulties or particular psychological presentations. We're able to comment on things like secondary factors that are impacting thinking skills. So, to what extent does difficulty with sleeping or medication seem to be impacting cognition? And we're able to help people identify some of these modifiable targets for things that we can work on. And to also comment on prognosis. So, just this morning, I was helping someone understand, based on their pattern of strengths and weaknesses, could they return back to work? Or is this someone who's getting worse over time, staying the same, or improving? And what would be some ways that they could improve their cognition? What are some recommendations that we might have for ways to improve cognition? And so with that, maybe I'll take a break and I'll invite Leslie back in, and maybe what we can do is if people are curious, we could talk a little bit about some memory strategies. But I'm more interested in spending our time together talking about things that people have noticed and making sure we have a good amount of time for questions and discussion. So maybe what I'll do is I'll keep my slides for later in case we want to come back to them. But for now, maybe we'll switch over to the discussion portion.
Yeah, thank you so much, Dr. Gould. That was excellent and provided a really nice overview of neuropsychological testing. Just on that note, while I had the chat open, Dr. Cobley is asking, are these tests sensitive enough to assess persistent symptoms secondary to a concussion?
Yeah, so it's a great question. And I would say we don't have particular tests where performance is pathognomonic of persistent concussion. So, for instance, based on a neuropsychological battery, I don't think you could say this person, yes or no, is experiencing persisting symptoms or be able to comment on the specific etiology, like based on difficulty with this type of thinking skill. I think that this particular issue is at play. But we can develop hypotheses. We can comment on whether performance is stronger or weaker than what we'd expect, whether it's a typical profile or atypical profile. And we can also comment on the degree of disturbance. So someone may have very mild difficulties with cognition, someone may have moderate, someone may have kind of globally suppressed cognition versus more isolated weaknesses. So within the caveat that we're not diagnostic, we can also provide a lot of nuanced information about a person's particular pattern of strengths and weaknesses and comment on the role of mood and other sorts of aspects in their cognition. So we are able to provide feedback and the impact of cognitive symptoms that may be secondary to some of the physical sequelae from a brain injury.
Excellent. Thanks so much. And just a reminder to everyone, if you do have questions, if you could please put them into the Q&A. Jim is asking, what part of the brain causes issues with splitting attention? I can't articulate a solution to a problem if there's another conversation going on. Sometimes I don't release cash to a cashier if there's a distraction.
Yeah. And so, that part of our brain is more of a network activation. And so what we need to be doing in that moment is inhibiting irrelevant information and activating the target information. And so our frontal lobe kind of is in charge of our attention network and helps to say, we need you to be active or we need you to quiet down. So thinking of the symphony, imagine the conductor of the symphony saying, okay, strings, we need you loud right now. And percussions, we need you to be quiet. And so the frontal part of our brain is kind of plays an important role in dictating how attention is filtered. And we have these distributed attention networks that draw on our parietal lobe. And in concussion, sometimes the process of inhibiting irrelevant stimuli and staying kind of targeted to the task can be compromised. And another type of brain region that's been implicated in that is something called the thalamus. And it's the relay station of the brain. And its job is to take different types of information and transfer them to where they need to go. And some people at our hospital believe that dysregulation or dysfunction in that part of the brain can also contribute to that type of difficulty of being able to filter out irrelevant things and focus on target things. And so, in terms of what we recommend for that, there's not a magic cure. People are working on different strategies and approaches for it. There's a group at Sunnybrook that's thinking about, well, to what extent could something like repetitive transcranial magnetic stimulation be helpful for people who have that particular type of difficulty? So, at the level of research studies, they're trying to understand, can changing the network activation somehow facilitate that type of attentional filtering? But there's nothing yet of clinical kind of readiness to offer our patients. And I'd be curious about Leslie's thoughts for this, but I find that mindfulness training can be helpful for individuals learning how to regulate their attention and being aware of, oh, here's a moment where I'm feeling overloaded, I'm not focusing, bringing our attention back to its center and refocusing and coming back to the task. So kind of the behavioral approach of taking our attention, refocusing it, and bringing us back to kind of our core task can be a type of skill that that can be strengthened, and it's something I've done with people with ADHD as well in terms of learning that ability.
Yeah, I absolutely agree, especially these days. There's so many things pulling our attention. That ability to be able to sort of rein it in can be really great training. Um, the question, is there any evidence for creatine for, just says for traumatic brain injury, but I guess in the role of creatine in cognition and DBI?
Yeah, I know that there is some anecdotal evidence, but I don't think it's quite reached kind of a higher level of class of evidence where, for instance, the practitioners at our hospital would feel comfortable recommending it. And so I have read a couple of studies that have kind of reviewed people's use of creatine, and how it can be helpful for um, brain energy in terms of kind of how we use ATP in the brain. And so there's some interesting research, but I'd say it hasn't met the level of sophistication yet where one group has been prescribed creatine, another group hasn't. And it's kind of a double-blind controlled study, kind of meeting that scientific rigor for one of our hospital docs to say, you know what, I think it's promising, and it kind of meets a level of scientific evidence where I'd feel comfortable prescribing it. Um, but if people feel comfortable using kind of a supplement like that and they have noticed a benefit, I'd definitely recommend talking to your healthcare team about it and kind of checking to make sure there's no contraindications. For instance, there can be some risk of putting a little bit of strain on your liver when we start to use creatine. So always making sure we're not making things worse by adding things, and don't be shy about talking to your healthcare team about it.
Hmm. Yeah, absolutely. Thank you. Okay. Okay, Lee is asking, this is interesting. This came up in our discussion before we started. How often do you encounter patients who seek treatment for persistent symptoms and are instead diagnosed with FND or functional neurological disorder, or concussion symptoms are dismissed as psych elements instead? I am seeing that more often in the patients I work with in Texas.
Yeah, it's a wonderful question, and I encourage people to learn more about functional neurological disorders because I think rather than stigmatizing some of our patient population, we can actually empower them by finding the right treatment for the right presentation. And so there are wonderful approaches within the world of functional neurological disorders that we can apply to our patient populations, like people with persistent concussion symptoms. And so overall, what I think the literature tells us is that there may be what we call a functional overlay on some individuals who have persisting symptoms, where there is a non or maybe it's better to say where there's a psychological explanation for some of their symptoms. And that's not to say that there's not a physical one, but there's a certain psychological component to symptom presentation. And if we can put our finger on that and understand that as clinicians, we can actually help individuals be able to experience better symptom control and improvement and return to function. So, an example I give from a patient population I see a lot is epilepsy. And there are some of my patients who have both epileptic seizures that are recorded on video EEG, but they also have functional neurological episodes or non-epileptic seizures that, to my eye, I would say 100% that's an epileptic seizure. And so together we'll review both of these events. We'll look at how it feels in the body, what kind of sensations they're experiencing, the triggers when they occur, and one thing some of our patients have noticed is they appreciate like those are non-epileptic events, and boy, is that wonderful. I can actually start to reduce some of my medications or appreciate which events are epileptic and which are non-epileptic. And it can actually be wonderful for overall functioning and return to previous levels of functioning. And so I'd encourage all of us as clinicians to continue our own growth and development so that when we are aware or see an opportunity to take some of the wonderful work from functional neurological disorders and apply it to our populations, I think it can be a wonderful way to help people experience less symptoms if their presentation fits that pattern.
Great. Thank you very much. We've got lots of questions coming in. Is fMRI useful for treatment or for showing PCS, persistent concussion symptoms, to an insurance company? If so, do you offer at your clinic or how do you get one? Or is something else more useful?
Yeah, it's a wonderful question. And so, there's a whole field of neuropsychology and behavioral neurology that's interested in what we call symptom validity and understanding if someone says they have a presentation, is there a biomarker or some sort of biological evidence that it's occurring? And as of yet, fMRI has not met the standard for um, a test with a high enough sensitivity and specificity to put someone in the scanner and say this person is experiencing persistent concussion symptoms. So it doesn't have quite the scientific rigor to be used in that way. But if we look at groups of individuals who have persisting symptoms and compare them to groups of individuals who don't, there are certainly patterns of activation that are supportive. And so I think in the next period of time, like some individuals, more likely in the US, will be interested in using it as a test of kind of continuous symptom burden. There's the world of athletics that are very interested in understanding, are there particular biomarkers from the perspective of inflammatory markers in the blood that indicate that someone has had a concussion or is still concussed? And so I think in the future, I would expect there to be better biomarkers that indicate someone is symptomatic versus non-symptomatic. But I think in my use and the use I see more in the Canadian healthcare system, I think we tend to believe when people are experiencing their symptoms that they are there, even if we can't see them. And so I'm sure Leslie's and I have talked about this idea of a silent disability, that some individuals look fine and they look well, and they're being asked by their insurance company or by others, like, why can't you return to work? And because it's not like a broken arm or some sort of other physical manifestation, it's tough to convince people sometimes that this is what I'm experiencing. So, um, yeah, maybe I'll just stop there for a second and and
Hmm.
and just leave it there.
And yeah, on that note, we have someone else saying, so if you were extremely high performing before, I presume it, perhaps in a high level type workplace, how does the assessment change and how can you show this to, and again, they're referring to an insurance company.
Yeah. And so clinical history is really important. And so I'll be really careful to gather the types of activities people were doing. And so if someone were a trial lawyer, I'd expect them to have really good fluency and vocabulary and confrontation naming. And if we're seeing a real difficulty in that ability, that certainly points to a decline in some of those skills. We have harder versions of tests where we can scale it up to a really difficult level. And so, thinking about an analogy with exercise, imagine if your trainer said, I want to give you the strongest weights we have in the gym to kind of test your strength. That's what we could do in terms of neuropsychological testing. We could give you the most demanding versions to see within yourself, do we see any relative inefficiency, but also relative to the population.
Hmm. Absolutely. Um, Crystal is saying she is working with a client following a motor vehicle accident with persistent symptoms. The client is a lawyer in a very cognitively demanding role. They've reduced her caseload, but the work remains high, complexity, and time sensitive. She's currently on a graded return to work with reduced hours and days, but even with those accommodations, sounds like she's still struggling with performance and is not tolerating progression. From your perspective, at what point does this pattern warrant a full neuropsychological assessment? Also, in your practice, is a neuropsych assessment ever used to inform whether someone can realistically meet the cognitive demands of their role long term, or whether an alternate role or vocational direction may be more appropriate?
Yeah, so it's a great question. And so I do see that pattern in some of the patients in the hospital where people are trying to return back to work. And even with the graded accommodations and certain hours or responsibilities that get added over time, that they're not doing well. They're not performing at the level they previously did. They're not responding well to demands being increased. And I sometimes think of that as developing a culture of failure with our patients. And I prefer to see a culture of success where we have kind of increased demands based on performance that's tolerated. And so I think when people start to have difficulty at work, they start to develop feelings about that difficulty and they start to potentially doubt their abilities or they start to perform more poorly because cognitively they're struggling with the demands of the role and adding more doesn't get better performance. It actually causes performance to decline. And so in situations like that, I think that absolutely does warrant a neuropsych assessment, especially if we can be helpful to characterize their cognition. And I think, it can be used to advocate for our patients to help say, what is someone capable of at this moment? What is a reasonable expectation of what are areas that they are struggling with? So, for instance, in this example, let's say this person really struggles with sustained attention or with cognitive stamina. Maybe we could make recommendations about how to change the environment to work with some of those areas of weakness and take advantage of areas that are stronger, such as maybe memory or visual spatial skills. And so being able to use the neuropsych to advocate for patients based on data can sometimes be helpful in terms of convincing individuals that one, what we're seeing is real and characterizing it and quantifying it, and then using it to advocate for our patients as needed.
Great, thank you. We have a lot of questions, and so I'm going to kind of condense because we've got several that are asking. They're hearing a presentation and they're thinking, "How do I get a neuropsychological assessment?" We've had a number of questions saying, how can someone get a neuropsych assessment through you or through UHN? Also, a question about, are there any research studies that are ongoing that could help someone get some testing in this regard?
Yeah. So I'd recommend for people to take a look at our resources. I'm sure we'll send kind of the online version of how to access the Canadian Concussion Center, and hopefully there's links to projects that Carmela or Charles have on the go. And Leslie, please feel free to chime in about things that you know about that are on the go. But we do have the Tele-Rehab Center with wonderful resources for patients related to either mood or particular strategies for how to um, cope with brain injuries or how to work on particular abilities with particular programs like goal management training. To answer your question, unfortunately, our services are limited to current neurologists or neurosurgeons at UHN. And so, in order for someone to access neuropsychology, they'd have to be a patient of the Canadian Concussion Center. And through the neurologist or neurosurgeon there, they make a referral and they say, "Hey, Dave, can you see my patient for detailed neuropsychological assessment?" Dr. Tartaglia is very fluent with cognition, and she feels comfortable doing neuropsychological testing with some of her patients. And so we only see some of the patients that she sees. And so by becoming a patient of hers, for instance, or Dr. Tatter, or other providers, that could be a way to have access to a detailed neuropsych assessment.
Hmm. Yeah, I mean for the Tele Neuro Rehab Center for ABI, if you go on and Google, I think probably KITE,
Yep.
KITE, Tele Neuro Rehab Center, and while you can't access a full neuropsychological assessment, they do offer free, as Dr. Gold was saying, groups that are really can be helpful from both, a mental health and cognitive perspective. So it is challenging uh, I think for some people to access neuropsychological testing, if people have coverage to do it privately, if they've been involved in a motor vehicle accident, that sort of thing becomes a bit easier. I think Cheers, CHIRS, Community Head Injury Resources, does offer some neuropsychological assessment, sort of at a lower cost to individuals.
Yeah, for individuals with moderate brain injuries. Yeah,
Okay.
yeah, yeah.
Okay. I'm just checking the time to see what we can get in. Anne is asking, are there assessments that can identify cognitive fatigue? When I did a cognitive assessment, it was normal. Presumably, she performed normally because it was simple and also relatively quick.
Yep.
However, cognitive symptoms become worse over time depending on the complexity of work tasks I need to do.
Yeah, and so I think um, one way I capture that is I'll sometimes, over the course of a 6 hour testing day, I'll do something at the beginning of the day and something at the end of the day. And what someone could do at the beginning of the day, they can't do at the end of the day. And so that provides strong evidence that performance changed over time. But I capture it behaviorally. I've had patients, clients who are so fatigued midway through testing that they actually sleep in our testing room. And some have even stayed at nearby hotels because they don't feel safe driving back to Kingston or Belleville. And I see it and I believe it, so I capture it behaviorally. But I guess psychometrically, one way it can be captured is with a lengthier battery, being able to compare either similar tests at different times of the day or trends in performance as you exert yourself cognitively more.
Mhm. For sure. Thank you. What are some activities or exercises that one can do to rebuild thinking skills like multitasking, memory, word recall?
Yeah, I'm so glad someone asked about that because I didn't go through my slides about kind of treatment or lifestyle modifications. And so what we know is that you're not missing anything by not doing brain games or brain training. Those types of activities help you get better at the particular skill, but they've yet to show transfer to broader everyday living or your practice as a lawyer. So we know that if you do a particular type of skill, you might get better at it. If you're practicing inhibition skills, you might get better at inhibition, but it would only help you on the video game, not in real life. And so to address that, I think about the value of trying to simulate everyday thinking activities. So if you're struggling with learning and memory, being able to work on strategies that help get new information in, help you retain it, and help you get it out. So, for instance, just earlier this week, I was working with someone on the task of how do I remember information for this family reunion that I have coming up. I don't remember which uncles go with which kids, and it was a struggle. And so we worked on a strategy called retrieval practice, where information is practiced getting out of memory instead of just study, 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 which kids go with which aunts and uncles. It was a matter of using cue cards and trying to retrieve on their own which individuals go with which family members and what their names are, and being able to do that on our own in a way that if you're not successfully retrieving it, you go back, try to think of a way to meaningfully encode it and get it back into memory. And so I think there are people who are helpful at doing memory strategies and cognitive strategies, and those can be helpful. But I think overall, when I reflect on broadly what are things you can do, and I think living well is a good example of what we can do for our thinking skills. So a good diet, exercise, watching our stress levels, having some sort of relaxation and practice that helps us kind of stay calm and well. So living well is actually good for our thinking skills. And then once you're given some thought to lifestyle, it would be actually doing things that involve thinking. So going to a museum and practicing learning about a whole new area that's something you didn't know about, and then going home and teaching someone about it, or trying to learn a new instrument or learn a new language. So anytime we're learning, we're using our thinking skills, and that can be a way to stimulate our brain. So every time we have a new experience, we're doing something called neuroplasticity, where our brain is growing in order to try to accommodate that new experience. So once people have given some thought to lifestyle, I encourage them to think about thinking activities that are stimulating whatever they're interested in, whether it's books or art or learning about sports or whatever you're curious about. Practice learning and practice teaching or retrieving that information. And I think that's something that we know based on research is good for your thinking skills.
Great, thank you. Let's see here. Jason was asking, generally speaking, is there any way to explain why a person might not be able to do something like simple math, but be able to read, remember something that might be complicated, and then the next day or next week be able to do the math, but not the complicated reading and writing?
Hmm. So yeah, some really big variabilities patterns. Yeah, nothing comes to mind in terms of why it's available some days and not in others. Like I'd be curious to maybe work with that individual and try to understand what contributed to that. But in general, if something is inaccessible and they can't do it, then I'd be curious to know what's different in the times they can do it. And so I'd want to maybe learn from that individual's successes to say, well, what happens when you achieve that math and what happens when you don't? Is it something about how you're feeling or a medication or a medical experience or the mood you're in? Like just trying to understand it because maybe we can learn from the successes for when the success isn't there.
Hmm. Absolutely. Okay, thank you so much, Dr. Gold. It was a really excellent presentation, and we have so many questions. I apologize that we couldn't get to all of them. But just a reminder, there will be a very short survey coming your way. And if you did have a question that you still would like to get answered, please feel free to include that. There is on the survey room for comments. Just know that they are anonymous. So if you want us to get back to you, if you can just include your email address, that's always helpful. But we really appreciate getting your feedback and suggestions. Um, just so that you know, we're going to be returning in 2 weeks. We have a new speaker in our series, Jenny Diamond, who's an occupational therapist. She's going to be with us and be talking about return to work after concussion. So thanks so much. And thanks again, Dr. Gold.
Thank you.
Good night.